Good afternoon and welcome to the UI Health Community Conversations. The UI, for those who this is the first time joining the show, the UI Health Center, UI Cancer Center is creating one of the country's first community-focused cancer centers, utilizing partnerships with Chicago civic leaders and community partners. We are creating a new model on how to address the cancer burdens and disparities found in our Chicago communities. And today, my name is Perrin Green, and today we are joined with urology resident Dr. Ryan Dobbs, who works with Dr. Michael Abram, who is the director of urology oncology, as well as Dr. Peter Gann, who is the co-leader of the prostate cancer working group at UIC. Welcome, Ryan.
Hey, well, thanks for having me on.
No problem. So you've been invited here to discuss prostate cancer today. Also to talk a little bit about the enact trial, which is research focusing around prostate cancer. So before we get into that, do we want to give the audience an explanation of what prostate cancer is, why is it important, the screenings and things of that nature?
Sure. So prostate cancer is actually the most common non-cutaneous malignancy or cancer in men. It typically affects men past the age of 50 and oftentimes doesn't have any symptoms. And so one of the things that's pretty important is getting annual screening or every other year screening for prostate cancer. Screening for prostate cancer consists of a physical examination as well as just a blood test called the PSA. And the PSA stands for prostate-specific antigen. It's a little enzyme or kind of chemical that's made by the prostate and can be elevated for a couple different reasons. Most commonly either due to prostate cancer, which is why we use it as a screening test, but it can also be just a marker for inflammation or infection in the prostate. The prostate itself is about a walnut-sized gland. It sits around the urethra in the where the men pee out of, and it contributes some fluid in kind of normal sexual function. As men get older, it's a common place for getting cancer, and so I think the screening and kind of checking on that is really important. I think it's important to mention that for prostate cancer, it can be kind of two different forms of it. There's a number of men that will eventually develop prostate cancer that's kind of indolent or quiet. And that can oftentimes be managed by just carefully watching it or doing biopsies over time. Other men can develop aggressive prostate cancer, and that's the kind of prostate cancer that we want to treat, either with surgery, like robotic prostatectomy, or radiation treatment. The thing that we worry about is if prostate cancer metastasizes or spreads outside of the prostate gland. When that happens, it goes into the lymph nodes as well as the bones, and at that point it's no longer curable. And so in that case we usually treat it with either chemotherapy or hormone management. But with good screening and careful attention to it, very few men will develop metastatic or distant prostate cancer.
Definitely. And once again, what I do want to inform that guests are definitely welcome to call into the show. The number to call in is 312-738-1060. That's 312-738-1060. So a lot of your research and Dr. Gann's research around prostate cancer involves the development of tissue-based biomarkers and digital imaging. And before we go deeply into the research, can you give us an explanation of what biomarkers are?
Sure. So we actually already talked about one of the biomarkers that we use for prostate cancer, the PSA, or the prostate-specific antigen. That was a test that was initially developed back in the 1980s, and the reason that they initially developed it was to look for people who would have recurrence of prostate cancer. There was a large clinical trial that they did in the early 90s that demonstrated the effectiveness of PSA screening for the detection of prostate cancer. And I think that's where kind of it's been more broadly taken into the public knowledge in terms of the blood tests that people get on an annual or every other year basis. Obviously, this has gotten a little bit of controversy because sometimes there can be some overtreatment of prostate cancer that would be generally indolent. And so recently, a couple of years ago, the National United States Preventative Task Force actually recommended against PSA screening, even though we've seen a dramatic decrease in the rates of metastatic prostate cancer since the introduction of PSA screening. And I think PSA screening is particularly important for people that have a family history of prostate cancer, as well as African American men. Both of those groups have a much higher risk of developing prostate cancer. In terms of biomarkers or blood tests, we have the PSA, and some of our research is looking at how we can make more accurate and more detailed information about prostate cancer to try to figure out whether it's the aggressive or benign type. And so one of the things that I think is really exciting that we're working on right now is a trial called the enact trial, which is abbreviated for enabling or engaging? Engaging. What does it stand for?
The enact trial?
Yeah.
I'm not sure it has an abbreviation to it yet.
Yeah, it's the novel cancer treatments thing.
Oh, okay.
Yeah.
Yes.
I don't remember the whole thing about it, but what it's looking at is a genetic analysis for prostate biopsies. So usually, kind of the sequence of events is a man goes to his healthcare provider and he gets a examination and he gets the blood test. He gets the PSA test. If that's elevated and there's not a good reason for it to be elevated, like infection or recent trauma or anything like that, usually what we would recommend is to do a prostate biopsy. And in that, we do a little procedure. We take out little cores of samples of the tissue, and we send that off to the pathology lab. In the pathology lab, they look under those cores under the microscope, and they see whether or not the tissue looks like cancer or benign. One of the things that we're kind of interested in doing is using an analysis called the Oncotype DX, which looks at a genetic panel of tests for those tissues and allows us to see if there's mutations in the tissues that would be concerning for aggressive prostate cancer. And so what we're trying to do is kind of validate that test at UIC as well as Cook County and see if that test works well for helping inform men about the aggressiveness of their prostate cancer.
Okay, definitely. Thank you so much. So where does the, and you touched on this a little bit, but particularly where does the use of technology and digital imaging come into play with this?
Sure. Imaging, I think, is also a particularly important aspect of kind of trying to figure out the prostate cancer puzzle. There can be a couple different uses of imaging in the treatment of prostate cancer. In one example would be if someone has an elevated PSA and they've had a biopsy and the biopsy came back benign or not cancer. Sometimes that PSA or the number can keep going up. And so I think we're trying to, in that situation, we're trying to figure out why is that marker, why is that biomarker going up despite kind of evaluating it. And part of the issue is that when we do the biopsy, we're taking only very small samples of the prostate. So one of the things that Dr. Michael Abram is looking at is actually using MRI, or magnetic resonance imaging, to evaluate the prostate prior to biopsies. And the reason we would do this is that when we can evaluate the prostate with imaging like MRI, we can figure out if there's a specific area in the prostate that would be particularly helpful or beneficial to sample for the biopsy to detect whether or not there's prostate cancer. The other thing that we could use for potentially imaging would be if a man is diagnosed with prostate cancer and we want to evaluate whether or not the cancer has spread.
Okay.
I think we have a caller.
Yeah, we definitely have a caller. Caller?
Hello.
Hi.
Hi.
Hi. Thanks for taking my question. So I wanted to know, in terms of warning signs, what should you be paying attention to? Like if your father or your uncle is going to the bathroom more frequently, or is there like a certain age you should be watching for when you're kind of on the lookout and may need to see a specialist? What should jump out at you health-wise?
Sure. So the current recommendations for the AUA in terms of PSA screening are that men between the ages of 55 and 69 should get a PSA test every other year. The potential groups of people where you might kind of change that approach would be people that if they have a family history of prostate cancer, or if they're African American. Oftentimes people will recommend starting screening either if you have a family history 10 years before their father was diagnosed, or in African American men, sometimes people will recommend starting screening at 45 or 50. In terms of symptoms, part of the challenge with prostate cancer is that there's not a lot of specific symptoms for evaluation. Obviously, as guys get older, one of the real common things that happens to a urologic problem is benign prostate hyperplasia, or BPH. And so that's when the prostate grows on the inside, and it can kind of narrow the urethra, and it can make it so that men have to go to the bathroom more frequently, or have less warning, or get up in the middle of the night to go to the bathroom. So I think, obviously if somebody's having symptoms like that, I think it would be good to go see a urologist, and they can kind of help figure out whether or not this is something that's benign or something that would be more concerning for cancer. But either way, a urologist can offer either medical treatments or surgical treatments that can help with those symptoms.
Definitely. And thank you so much for that call. And thank you so much for that call. And if anyone else has any more questions, please feel free to call in at 312-738-1060. And Ryan, I do just want to ask a general question. We've talked a lot about prostate cancer and PSA screenings. What is one of the best ways for people to actually get a PSA screening if they're interested?
Yeah, so I think that there's a couple options. A lot of the time you can get your PSA at your general practitioner or your family practice doc. You don't necessarily even need to go see a urologist to get a PSA drawn. I think some other options, oftentimes there's health fairs or kind of health events where people will offer prostate cancer screening with a blood test and getting a PSA. Or obviously they can come to the University of Illinois Chicago and see one of our urologists here, and I think we would be happy to help out. Okay, definitely. And is there, outside of the enact trial, are there other research that you have been a part of, or that you currently are a part of at the at USC that's going on now? Yeah, we have a number of research projects that are going on right now. One of the ones that I think is really exciting is looking at some population-based statistics. We actually had a presentation earlier this year at the International American Urological Association looking at stage migration in African American men. Obviously at University of Illinois, we take care of a lot of African American men, and our population there is, a little bit different than some of the other hospitals in the city. And so, what was kind of interesting that we found in our study was that the pattern of stage migration in men, or the kind of stage of disease that they were having, was still improving over time between 2000 and 2013. And so I think that is certainly evidence to the fact that, perhaps that we're doing a better job screening African American men, or that we're getting the message out a little bit, and they're still getting some benefit out of the PSA screening.
Okay. Cool, definitely. Our goal at the U of I Cancer Center is to have the first fully community-based cancer center at USC, meaning we want to develop research and treatments that stem from and address issues that are most prevalent in the communities that we are present in. How do you feel your research and your work with biomarkers assist us in achieving that goal?
Hey, we actually have another caller.
Oh,
Yeah.
well, before you answer that, let's take another call. Caller?
Hi, I have a family member who has had prostate issues recently, and I was wondering, like, what's their best course of action? Would they be good for the enact trial? They haven't been yet diagnosed with prostate cancer, but it has been an issue for them recently.
So the enact trial is a trial that's looking at treatment after a positive biopsy. And so it is men that are diagnosed with prostate cancer that are part of the trial. I think if you're somebody who has a family member or somebody that is having issues in terms of prostate issues and urination, I think it would be very beneficial to see one of the urologists here, and we can kind of help sort that out. And again, part of that might be, doing the blood test to look at the PSA, doing an examination, trying to figure out, again, whether we not think this is something that's either benign, which we can offer medications or treatments for, or if we think that this is something that could be potentially cancer. If it is cancer, then that would be somebody that could potentially be part of the enact trial.
All right. Thank you, Ryan, and thank you, caller, for that great question. So while we do have a little time left, Ryan, and we're talking about research, especially research around prostate cancer, would you be able to, even assist us with talking about some of the myths versus the facts with prostate cancer?
So I think some of the myths would be that, all prostate cancer is benign.
And when you say benign, meaning?
I think that there's a kind of a common misconception that people think of, sometimes when they get prostate cancer, that's not something that necessarily needs to be treated. And again, I think it's kind of a complex question. So there certainly are prostate cancers that are very amenable not to requiring treatment. And those are, depending on the kind of grade or the way the prostate cancer looks under the microscope, those are people that could potentially go on active surveillance. Active surveillance is a concept that was initially introduced probably about 10 or 15 years ago, and it was trying to identify which men with low-risk prostate cancer could be watched over time. And the watching over time consists of a lot of the things that we're already recommending for men, such as the examination and also the blood test each year. And then depending on kind of the grade and the characteristics of the prostate cancer, maybe even repeating biopsies over time to make sure that the cancer isn't changing or different than what initially came in. So there's actually a number of men that we have at the University of Illinois that are on this active surveillance. And so each year or two, we do a biopsy. We continue to watch their PSA. We continue to, keep a close eye on them, but we don't have to do anything like surgery or radiation to treat the prostate cancer because it's benign. Now, the other thing is that, there are men that have very aggressive prostate cancer, and that's the kind of prostate cancer that we would worry could potentially metastasize or go into the lymph nodes or the bones. And so those are men that, would either be candidates for looking at the enact trial and trying to figure out if we can help kind of figure out how aggressive their cancer is, or those are people that we would recommend surgery or radiation for. And the University of Illinois offers both radiation oncology that does the radiation treatments, as well as surgery options, robotic surgery.
And then also you were touching on some of the myths versus the facts with prostate cancer. One of the major concerns with men who are diagnosed with prostate cancer is sexual incompetency. So and that does occur with some of the treatments. But can you just speak, can you speak on that in terms of myths versus the facts? In terms, why is it important to get the treatment, even though it may cause other issues?
Sure. So the trifecta, or the three things that we're really looking for our outcomes for prostate cancer, are cancer control. So that's making sure that when we do a surgery, that we get the cancer and we take it out. The other two things that we worry about are the most common side effects, and also things that impact people's quality of life. And so those are, sexual potency, our ability to have erections, and then also urinary incontinence. And there's a couple reasons that those happen. Erectile dysfunction is because the nerves, the cavernosal nerves that men use to get erections, run alongside the prostate. And so one of the real great advances in surgical technique has been the development of the nerve-sparing prostatectomy that was initially done by Patrick Walsh at Johns Hopkins. And so his technique on that was to be able to separate those nerves from the prostate when they're taking it out. And so, with the development of robotic techniques, we have very good magnification and very good dexterity to be able to separate those nerves from the prostate and hopefully preserve sexual function if that's appropriate based on the kind of severity of the cancer. The other thing that we worry about would be urinary incontinence or leakage. Urinary incontinence or leakage is very common after surgery for prostatectomy, but usually gets better over a course of 6 to 12 months after the surgery. And the reason that happens is that the prostate sits around the urethra, where men pee out of, and so removing that portion of it and anastomosing, or connecting everything back together, could potentially damage the sphincter that men use for control of urinary symptoms. So again, that's something that's very common, but oftentimes gets better, and can get better with some exercises like Kegel exercises after surgery as well.
Okay. And we talked a lot about prostate cancer. Are there any things in terms of diet that we can do to help prevent prostate cancer?
So people have looked at a lot of different things to try to figure out if there's anything that would be potentially preventative for prostate cancer. Some of the things that have been looked at and may help, oftentimes people talk about lycopene. And so it's actually based on one of the trials that was done at the Jesse Brown VA. And that's something that's common. Most times people refer to it in terms of tomatoes. And then, another thing that has shown some efficacy are like soy products. So like soy milk or, things, tofu or something like that. Sometimes people have seen some association between diets that are rich in soy products, and those might have some small preventative effect. I don't think that there's any specific food that prevents prostate cancer, but obviously, I think eating well, exercising well are just good pieces of advice for a lot of things, and probably wouldn't hurt for prostate cancer either.
Okay, and so you mentioned physical activity. So is that a big piece of, I don't want to say preventing, but being physically active? Is that also a good piece to kind of help in the prevention of prostate cancer? Obese men do have an increased risk of aggressive prostate cancer, and I think in terms of general urology, we always try to stress good physical exercise as being an important aspect for erections and sexual function as well. It's commonly that the cardiovascular system, if it has issues, can lead to problems with sexual performance. So I think just in general, we recommend physical exercise. Okay, and thank you so much to Ryan for informing great facts on prostate cancer, and also thank you for joining us, and that basically wraps up the show. We hope you can join us next week. Thank you again.
All right, thank you.
All right.